Good morning, everyone. It's great to see so many people here. So, as Celia's already mentioned, the CQUINs for 2019-20 haven't completely been finalised and approved by NHS England, but I'm pretty certain that we're going to have an antimicrobial resistant Sequin that should be published next week. So I'm just going to focus on the antimicrobial resistance part of the current Sequin and go through some of the data and how we're performing at the moment. And then I'll be talking about the two potential new Sequin indicators for the new AMR Sequin. So the current Sequin at the moment contains an antimicrobial stewardship indicator that has a slightly tougher target compared to previous years. So what we're looking for in the antimicrobial stewardship indicator is that our sepsis prescriptions should have a 72-hour antibiotic review documented by an appropriate clinician, and by that we mean an antimicrobial pharmacist, a ward doctor ST3 or above, or a microbiologist or ID physician ST3 or above. And then if the route is IV, post the 72-hour review, then that should have a rationale documented in the notes. So why are we using IV antibiotics post 72 hours? And as you can see, Q2 data shows that 70.8% of our antibiotic prescriptions that are reported to PHE for the Sequin have these three components. And then if we have a look at the table below, this shows our antimicrobial consumption targets and the percentage of trusts who are meeting these Sequin targets in Q2. So just below 70% are meeting the carbapenem target, so that's slightly easy to achieve. And then the harder components are meeting the total antibiotic target and the proportion of access. So just about a third of trusts are currently meeting those two sections. So that's the current Sequin at the moment. Now, I'll just give a little bit of background as to why the 2019-20 Sequin is significantly changing. So we already know about these two national ambitions. We have to halve inappropriate antibiotic prescribing by March 2021, and also we have to halve healthcare-associated gram-negative bloodstream infections by March 2021. Now, Jonathan's already mentioned about the long-term plan, but antimicrobial resistance was discussed in this plan. And it states that the health service will continue to support the delivery of the new National Action Plan. And I think already mentioned in Jonathan's talk, one of the many target measures documented in that National Action Plan are to reduce UK antimicrobial use in humans by 15%. By 2024. And a couple of months ago, in October 2018, the House of Commons Health and Social Care Committee report on antimicrobial resistance was published, and that clearly outlined the need for more challenging targets, particularly for primary care, but also for secondary care as well, in terms of antimicrobial prescribing. As you can see on the graph on the right-hand side, this is data from the ECDC from November 2017 from their report, which summarises antimicrobial consumption in hospitals across the EU. And as you can see, it shows that the UK has the third highest consumption in the EU. So the 2016 National Point Prevalence Survey that was led by Public Health England kind of identified two important areas where we could improve. So the Point Prevalence Survey showed that 43.1% of surgical prophylaxis prescriptions were deemed to be inappropriate in terms of treatment duration. And this figure was even higher for digestive tract surgery, and that sat at 68.6%. And as you can see, hopefully you can see at the back, the graph on the right-hand side shows where we are in England, and compared to Scotland, we're not doing as well. This is because Scotland implemented a surgical prophylaxis indicator for their quality improvement measures from April 2011 to September 2013. Now, they set a target of greater than 95% of their sample cases should be given as single doses, and the choice of antibiotics should be compliant with their elective colorectal guidelines. So median compliance for single doses was found to be 98%, which is really good. And there was median compliance with the guideline choices, and that sat at 93%. 100% of the Scottish boards that submitted the data were compliant with the single dose measure, and 70% of the boards who submitted data achieved the 95% compliance with antibiotic choice. And over that time period, they collected data for approximately 6,000 patients. So the other area that the Point Prevalence Survey identified as a particular issue was lower UTI prescribing. So within that Point Prevalence Survey data, 62.5% of lower UTI prescribing was deemed to be inappropriate. And we already know approximately 54% of gram-negative bloodstream infections are from E. coli, and we know that the primary source is urinary tract infections. We have the newly published NICE guidance for lower UTIs, and we also have the newly published PHE guidance for diagnosing lower UTIs. So this indicator, if we had one for UTIs, would join together diagnostic stewardship, so we'd be looking at diagnosing UTIs properly. It joins up with IPC because it links in with the gram-negative bloodstream infection agenda, and also ties in antimicrobial stewardship. So we felt that these two areas could potentially be really good CQUIN indicators for the next financial year. So hopefully this information will be published next week on NHS England's website. But the indicator we're expecting to see is improving the diagnosis and management of lower UTI in older people, because we know these are the people that are most at risk. There was a push, as Celia mentioned, from NHS England to really simplify the CQUIN indicators this time round. What we wanted to do was to help trusts meet these targets, and that's probably something that's quite difficult to achieve for the current CQUIN with the different 3 antimicrobial consumption elements. So I've already mentioned that we have the NICE guidance, so we would expect antibiotic prescriptions for older people who are treated for lower UTIs to be compliant with that guideline, and then the diagnosis should also be compliant with the PHE guidance. This will make more sense when we publish our data collection tools. And this time round, we've had involvement from different stakeholders as well. So we've gone out to microbiologists, infection diseases specialists, and also antimicrobial pharmacists to help guide and advise how we should be collecting the data. So the data should be submitted quarterly to PHE as the current CQUIN asks via an online portal. and there's going to be some slight differences in terms of the thresholds. So there's going to be a minimum and a maximum threshold to receive payment for the CQUIN, where if you hit the minimum level of 60%, unfortunately, no payment would be received, whereas if you hit above 90%, then you get the maximum payment can be achieved. And NHS England will provide some more information about this next week. I don't think my clicker's working. Can you move the slides on, please? Oh, thanks. So the next indicator is likely to be improving antibiotic surgical prophylaxis for elective colorectal surgery. So very similar to what Scotland did. We'd be looking at antibiotic surgical prophylaxis prescribed for elective colorectal surgery to be single dose, and there are exemptions there. So if there's a large volume of blood loss, or if infection or contamination is found during surgery, or the length of surgery is prolonged, then obviously further doses of antibiotic can be given. The choice of antibiotic also needs to align to local antibiotic guidelines, and again there'll be a data collection tool for this. Now, the number of data fields, you'll be pleased to hear, are very minimal. So there's just 2 data fields that you're expected to complete for this. And that's the number of doses and the antibiotic choice. Again, similarly to the lower UTI indicator, we'll be expected to submit data to PHE via the online portal. Now, for both of these indicators, we've recommended that junior doctors or ward pharmacists should ideally collect the audit data. Now, this is really just to allow the antimicrobial stewardship teams to free up their time to focus on quality improvement and lead the improvements within those indicators. So you might be asking, well, where have all the antibiotic consumption indicators gone to? So the carbapenem and access category indicators have been removed to simplify the Sequin, and this was very clearly stated by NHS England. So if we were to have an antimicrobial resistant Sequin for the next financial year, we had to significantly chop down a lot of the indicators. We've managed to retain total antibiotic consumption because we felt that was the most important component out of those 3 consumption elements, and that has now moved to the NHS standard contract. We'll be providing commissioners with some advice over the next few weeks, just so that we can ensure that acute trusts remain focused on reducing antibiotic prescribing. The baseline for this will be calendar year 2018, so it'll be up-to-date data, with a target of 1% reduction over the financial year. Now, there's also going to be a little bit of a change in terms of data sharing. So instead of acute trusts sharing their data with PHE, PHE will now be using consumption data from RxInfo Divine automatically. And if trusts think that their data doesn't align well with their internal pharmacy dispensing systems, then they are able to submit to PHE if needed. So further information should be available next week on the NHS England website. And as always, we host information on the NHS Improvement website as well to provide a lot of guidance and advice. We'll have frequently asked questions uploaded, as well as the data collection tools and the submission portals. There'll be a total antibiotic baseline data with the targets as well published on the NHSI website. So I think there's a lot of areas that we could focus on to improve these 2 areas of prescribing. But I just want to mention that we should be working towards using quality improvement approaches and collaborating more with our colleagues. So I like to think that these two new indicators allow antimicrobial stewardship teams to really engage with surgical teams and also with like urology and care of the elderly teams. So we should be collaborating more with IPC, AMS, microbiology and diagnostics, and hopefully we've brought all of those together with these two new indicators. We're running a workshop at 2 o'clock as well that looks at collaboration between IPC and AMS, so this aligns well. The Scottish Antimicrobial Pharmacy Group with Healthcare Improvement Scotland have recently published their good practice recommendations for surgical prophylaxis in adults, and this gives some really key recommendations and advice that might be useful to have a look at for the surgical prophylaxis indicator. And we're hoping this year there'll be a to dip or not to dip improvement national toolkit available, and this will nicely align with the improvements to lower UTI prescribing. And as always, I think it's really important to engage with other clinicians, and I think strong, effective, multidisciplinary leadership, so having champions at all levels, will really help to drive and push this area. So thank you for listening.